Hey guys, Don here. Welcome to the $1 Million Minute. We're going to go over the things that helped get the practice to the $1 million mark and beyond. This is a kind of a day of a Thursday, but before I do that, I always like to share the questions I get. I got a couple of emails from a couple of people that are listeners. One was, how much should a website really cost, and how do I know if my website is doing what it should do? And one of the challenging things whenever you talk to a website company, if you go to these conferences, they always do these website evaluators, and all of our websites have stuff wrong with them, right? All of them. So kind of my kind of favorite go-to, I think right now. So I have a couple of people that I like. I just like these people. So I think it's always good to go with good people, in my opinion. So Jim McDonald, he has Podiatry Growth, okay, and he also has a podcast called Podiatry Marketing, which is a good one. And then another one is Podiatry Content Connect, and I just like theirs because they have a pretty inexpensive subscription, meaning it's a kind of a per month type of thing, and they do a blog for you, which is good, and they kind of work on SEO. So those are a couple of good ones. Not like I don't not get paid by any of these ones, but these are the two if I was going to do it again and maybe had someone do it. But he was asking specifically how much should it cost you. So we used to use Patient Pop, which was referred to us by Athena, who was our soon-to-be previous EMR company. And they were $500 per doctor per month, and so it was about $2,000 per month. I think that was very expensive for a website, especially since they didn't do any content. If we wanted content, like a blog a month, they would charge us more for that. We could do our own blogs, but they wouldn't write any copy for us. I thought that was kind of expensive. That's why we kind of negotiated, and just a word to the wise, everything is negotiable. So if you say you're going to leave, they'll probably reduce the price. So if you're currently with a company that's expensive, negotiate. And so they came down to $250, which ended up being $1,000 per month, without any AdWords or anything else like that. And then eventually so what was the benefit of Patient Pop? They're really good at getting reviews. So we had the system of getting reviews automatically for our office. So every time someone came in, it had an integration with the medical record and got reviews. That's why it was called Patient Pop. Like you get these patients, and they can easily make an appointment on the website and things like that. And integrated into our medical record, like in terms of making appointments. So those are the benefits to it. But the problem is they're very kind of high end. I like the business model that they did. I think it's totally appropriate if you're talking about a business model. I just, as a consumer, I didn't think I should have to pay that much. What other kind of options or my thoughts are on this? So I think the other doctor that was asking me, he said, "Oh, how about like $1,000 a month?" I think $1,000 a month is fine. If you have someone doing like a blog a week for you, and if you have someone taking care of your website and it's SEO, so the difference is between AdWords and SEO. SEO, from what I understand, is it might take six months or longer for that SEO to rank, but then that's going to be like money in your pocket going forward because you have a high-ranking web page on that certain topic or that certain blog. Whereas AdWords is like once you pay it, it's done. Okay, there's no. And so the other thing would be, you want to collect emails so you can give them something of value. So I think that's another big thing. And having like an email newsletter that goes out once a week or something like that to your patients, I think that's absolutely essential, because the challenge now is we have all these patients maybe that come to our website. They're not ready for appointments right now. We don't capture their email. And the bigger problem now is everything is ranking lower on Google First Page. What I mean by Google First Page is, like, if patients Google you, and you're not on the first page, they're very rarely going to go down to that second page. And the problem with that, it's making it worse right now, is because we have these AI results. So if you put something in Google, it'll give you the AI results first. That's taking up real estate. Then it might give you the Google Maps or the Google business things. And then it'll give you the sponsored ones, and then it'll give you the organic ones. So you're kind of pushed further and further down the page. If you have really good SEO, you'll probably be higher on that page, but you're still going to be pushed down because of the AI and because of the maps. So that was my thought. I think 1,000 is fine. A couple of things I would really kind of encourage. One is a way to get reviews automatically, so you don't have to ask anyone for them. You can ask what its automatic is better. We use something called Swell, Swell. You can look it up for online reviews. There's other ones out there, but I think that is absolutely essential. I think getting emails is absolutely essential, and sending an email newsletter once a week is absolutely essential. And then I think in terms of the website, having like a way that people can chat with you, text message you, things like that, I think these are essential. And a Google business profile. If you don't have that, I've mentioned this before, but each doctor can have a profile for each location, and each location can have a profile. Ours got kicked out recently. We lost most of them, but they're all back except 2 right now. So we had to kind of just keep an eye on that, whoever is managing that for you. So you might not like to do that techie stuff, but something to might put money in your pocket. Another question that someone asked is who I use for my VA services. I currently have tried I have VA, and I also have scribes. So I think they're a little bit different. A scribe is someone that's listening to you during the encounter and helping you finish the note, do orders, things like that. So I use IKS Health, which used to be Acuity Scribing, but they changed names or they got bought out. I'm not particular to them. I'm more particular to my scribe. So if he moves companies, I would move with him. It's more about morale that's with me all day long than it is the actual company. The drawbacks of a scribe, as I mentioned this before, but it takes a long time to train them. It takes a good 3 to 6 months, and I'm on scribe number 3. So don't give up if the first one really doesn't pan out. If they I don't know, I've heard horror stories of them falling asleep or them not doing the notes well. So basically, the first 3 months or so, you're teaching them the templates. Every patient visit, you're going to have to share your screen with them and teach them how to do the notes. So that's going to be at the end of the day. It'll be during the day. Something else like that, so you can teach them how to do things and how to use your templates. And so it helps a lot if your templates are really good, because then there's less things for them to remember. And so that's kind of. And then the other thing would be a VA. A VA is like a virtual assistant that can help you with a lot of other tasks. There are a number of different VA companies that I have. I'm going to be actually putting this on the website. Podiatrypracticemastery.com. I'm going to put a footer down there. So one of these master footers, it's like we have all this junk that you don't want to talk about in the main website to not distract people. So if you look at my Central Mass Podiatry website, there's a big footer down there with it talks about everything that we do, the conditions, the services, and everything. So you don't distract people as they're kind of guiding them towards what you really want them to come in for, and it has everything else down there. So I'm going to do the same thing for Podiatry Practice Mastery. On the bottom, kind of the companies that I use or that I recommend and things like that, because everyone asks me these questions. Okay, so now this was a Thursday, 21 patients. I had 2 openings. One was filled, and so I guess there's only 1 opening. Okay, let's start here. First was an EPAT patient. This is a EPAT for peroneal insertional tendinitis. This patient failed a cortisone injection previously, and we did that shockwave number 1. He'll be back next week. Next patient was another patient that came in. This patient actually came in from Circle Health. I haven't really got many referrals from them, but they're an online primary care. I think this might be coming more and more because primary cares are hard to find, and so they were online and they referred to me. I don't know, maybe they Googled my practice or something like that, but they referred over. So I reached out to them to thank them. This patient, he got gabapentin, so a level 4 visit. He got Lamisil and the whole kit as well, and I'm going to do a 3-month follow-up with him. So he had some neuropathy, and he had nail fungus. Now, this one I'm starting to skip the sample, just so you know. I'm walking you guys through this. If you listen to some of the previous episodes, I'm always getting samples. I don't know. I don't have an in-office pathology, and like 90% come back positive, or probably about 90%. So on the ones I'm unsure of, I'm going to take a sample still, but on the other ones I'm pretty sure I'm not going to take a sample. I'm just kind of letting you know I'm changing my methods, and the way I explain it to patients is I say, we can take a sample, and there will be your insurance. There'll be, if there's a deductible, you might have to pay, or we can kind of treat this empirically, and then if it's not getting better, we can take a sample in the future. So I'm going to be trying it this way only so I can save doing these nail sample follow-up. So instead of doing a nail sample visit 1 and the follow-up in 3 weeks, I can save them 3 weeks. I can also save a low-level visit for me. And, if you're busy enough, I think this is a fine mode of practicing. If you're really slow, I would still do the 2-visit option. Next patient was another established patient for nail fungus. Same thing. I did the same thing, Lamisil with the biotin. Another patient was another Lamisil. So these are all like level 4 new this was a nail fungus follow-up. Next patient was a new patient. This patient came in for warts, kind of came in, and I did my presentation. I think this is a pretty solid presentation now. So if you haven't looked at my patient presentations, look at the one on warts. It's pretty solid now. You just kind of go through it, talk patients through it, and I had 2 recently that I've just kind of decided on the Swift based on the presentation. So I'm trying to make the presentation foolproof. I learned this kind of from Alex Hormozi, this guy that talks about marketing, and he said you have to make it so it is kind of idiot proof. So I'm trying to make it idiot proof for me so then I can train others to make it idiot proof, like train the other. I don't want to call it. I'm sorry. I'm not talking to my other colleagues that are idiots. Okay, I'm not saying that. What I'm saying is I want to make it super simple for me and have it work every time, so then I can teach someone else this. So it's either going to be with a slide deck, which I'm using right now, or it's going to be with like a written checklist. I'm doing the slide deck right now, and then the next step might be to do like a checklist. So for the main like 3 things that bring in most of the profit, let's say it would be Swift, Achilles tendonitis, and plantar fasciitis. That's kind of what I'm working on. So anyway, check out the slide decks. They got Swift number 1 set up 2 to 4. The next ones. Next was EPAT number 5 for a patient. The next one was I set up this patient, a follow-up, had x-ray, ultrasound, continued right heel pain, and I set up 6 shock waves for plantar fasciitis. So once again, I'm switching now from 3 to 6 sessions, offering that. I told you I had some coaching from Paul Hobro, so I'm getting used to asking for that and being confident enough in asking for the 6 sessions. Next patient was this was an add-on. It was a fibular fracture, tall cam boot, but it was non-displaced, so no surgery needed. Next was status post porokeratoma removal, feeling much better. Not totally gone yet, so I'm going to follow up with him via an email just to see how he's doing in a couple weeks. Next was a new patient, first MPJ pain. This is one where I'm trying to take what I learned from Paul about plantar fasciitis, like treating the symptoms and then the mechanics. So first MPJ, arthritic pain, hallux limitus, talked about the pain. He had a little gout too, did the injection for that, and I said, but to prevent it from coming back, to treat the mechanics would be an orthotic, and so that's why he got an orthotic. So I'm just kind of explaining my rationale and how I'm kind of incorporating treating the symptoms and then treating the mechanics of it. And when I explain it to patients that way, I'm hoping that it'll have reduced people not wanting to do the orthotics with me. So that was orthotic number 1 for the day. Another patient, this is a patient status post amputation in the hospital, and just a callus at the distal amputation site. They had a distal kind of a fifth ray amputation. That was the morning. Afternoon, EPAT number 2 to the heel. Then a patient came in for a second toe flexor tenotomy. Then a patient came in for Lamisil number 1. Once again, I skipped the sample, so they got the whole kit and everything, so I skipped the sample again. Next was EPAT number 1 for heel pain. Next was an IND follow-up. And the reason I did this IND follow-up is only because the mother was kind of intense, and I think she needed to be seen back more than the boy. Next was a patient came in for kind of a drifting second digit, mild bunion, drifting second overlapping the bunion, wanted to have correction of that. I discussed anatomic shoes and correct toes to start, and if that doesn't work, kind of doing a hammer toe repair for that patient. Next patient was a 41-year-old. We tried cortisone in the past for plantar heel pain. She had quite a bit of pain, and so I did shockwave for her, but she had quite a bit of pain. Like these ones that are in a lot of pain, gosh, she almost like passed out. So I went too high. I probably next time I would turn it down a little bit more. And I've had a couple of patients pass out because I go a little too intense, especially when her pain was like a really painful anyway. She's just delayed a long time with her plantar fascial pain. Maybe in hindsight I would have done another cortisone, seen her back in a month, and then started the shockwave. Next patient was a Lamisil booster, so this is the second follow-up for that. Next was a fracture follow-up. She overloaded the 5th met and had a fracture and a refracture on that area, so I scanned her for orthotics to offload that 5th metatarsal. And then the last patient of the day was a Lamisil booster. So anyway, that's the day. Hope that was beneficial. Check out that footer on the website. I'm going to put a lot of like recommendations and ideas on there. If you have any questions, I'd love to answer them or do my best to answer them. Or if you have any other tips that work really well for you, some people have been doing shouts out that they don't see matrices back and things like that. Just do a shout out either on YouTube if you're listening to it there or somewhere else. Tell me what's working for you, and I'll include it in this next podcast. Thanks.